Hi, my name is Tariq Adar, and today we're going to talk about lipids. We're going to review their biochemistry, their metabolism, and we're going to go through a bunch of cases. Now, I won't be discussing the mucopolysaccharidoses, even though they're technically lipid defects, just because they're involved in the extracellular matrix, and I intend to have a different lecture covering both the ECM as well as some of the diseases that are related to its misfunctions. And the other thing that we're not going to cover in terms of clinical cases is the dyslipidemias, but we're going to cover everything else, all the metabolic problems. All right, so fatty acid synthesis occurs in the cytosol, and it's fatty acid synthase that makes it. And you're going to make one palmitate using, nothing should shock you here. We're going to use NADPH as a reducing equivalent. We're going to use ATP, and we're going to use acetyl-CoA. None of this should be shocking. The cofactor is biotin. All right, that's important. The cofactor of fatty acid synthesis is biotin. Biotin is always going to be a cofactor whenever there's carboxylation. Please stick that in your head. Biotin, carboxylation, they go hand in hand. It was also the cofactor for pyruvate carboxylase. Every time you have a carboxylase step, like the acetyl-CoA carboxylase, you will need biotin. Biotin, carboxylation. Stick it in your head. All right, so what's going to activate? So you can go ahead and refer to the carbohydrate lecture to understand what insulin and dephosphorylation, how insulin mediates its effects by dephosphorylation, while glucagon mediates its effect by phosphorylation. But think about when you have fatty acid synthesis. It means your energy reserves are high. When your energy reserves are high, usually that's signaled by high glucose. And in high glucose, you have insulin. So what does insulin say? Hey, look at all this glucose. What if we just shoved it inside some fat cells? And that's exactly what happens. All right. And what inhibits it is going to be glucagon and epinephrine. Let's use our common sense. What does glucagon say? Hey, there's no sugar. And we put some sugar in the system. How? By inhibiting the synthesis of fatty acids and promoting their oxidation, their breakdown. All right. So when you have low sugar, glucagon and epinephrine are going to say, hey, we need sugar. So let's not make new fatty acids right now because we need to save our sugar and we need to break down fatty acids, break down fats into fatty acids. The other time epinephrine is going to kick in, well, when it's fight or flight, I don't think synthesizing fat's exactly what your body needs. What it needs is some rapid energy so you don't die, right? Dying is better than not dying is better than not having as many fatty acids. Right, which brings us to the other side of the coin, which is the fatty acid oxidation. And that's happening in the mitochondria, where the acetyl-CoA is going to generate NADH and FADH2, and then that's going to go to the electron transport chain, and then the acetyl-CoA is going to go to the TCA cycle and merge with oxaloacetate, and around it goes, and all happy days. And the point is, you got nice, juicy ATP for all your body's needs. And again, we're going to activators. We talked about glucagon, we talked about epinephrine. It's going to be protein kinase A activation. Remember, epinephrine and glucagon use GS, and you can go back and review the lecture if you don't remember. They stimulate G stimulatory G protein coupled receptors, which which activate adenylyl cyclase, which increases cyclic AMP, which leads to the activation of protein kinase A. And protein kinase A activates a nice juicy boy called hormone sensitive lipase. Why is it called hormone sensitive lipase? Because it's the lipase that's sensitive to hormones. All right? And there are hormones that signal it, one of them being glucagon. And there's some other stuff. Epinephrine is another. All right? And that releases the fatty acids for the beta oxidation we just described. And insulin is going to dephosphorylate and deactivate the hormone sensitive lipase. All right. So glucagon, epinephrine, they activate hormone sensitive lipase, and that releases free fatty acids. And insulin dephosphorylates the hormone sensitive lipase so it doesn't release the free fatty acids. And again, these free fatty acids, what's going to happen to them? They're oxidized, and the oxidation of a fatty acid requires things to be reduced. That would be NAD and FAD. And that leads to the development of NADH and FADH2. And the NADH and FADH2 go to the electron transport chain, et cetera, as I described earlier. So that's just to recap all of it. All right, so we see here, you get your triglycerides, you get your fatty acids, you get your fatty acyl-CoAs, but then how do you get inside the mitochondria? How do we do that? Well, there's a carnitine shuttle. All right, so the carnitine shuttle is associated with acyltransferases that let you move these free fatty acids to the mitochondria. This is necessary for long chain fatty acid metabolism. You don't want these bad boys to build up. You do not want free fatty acids hanging out in the cytosol unchecked. All right, so if you're a mutant for these carnitine acyltransferases, there's going to be damage, and we'll talk about that later. Chylomicrons and lipid transport. I'm not going to get too deep into this. In general, dietary cholesterol and triglycerides, like this juicy cheeseburger, are absorbed into chylomicrons. They in the villi of the small intestine, and they go into the lymphatic system, and then they're deposited in the bloodstream. This is left subclavian vein. And muscle and adipose tissues are perfused by capillaries, all right, that express lipoprotein lipase, okay? And that breaks the chylomicron into its remnants, glycerol, and free fatty acids. So what does the muscle and the fat do? It takes those free fatty acids for energy, all right? So muscle and adipose tissues, their capillaries express lipoprotein lipase, and that breaks down the chylomicron so that the muscles and the fats can harvest the free fatty acids. All right. Now, what's left is the glycerol and this remnant. The remnant either joins HDL or it goes to the liver, and glycerol also goes to the liver. So basically, to summarize what we just talked about, the dietary cholesterol and triglycerides you eat in your yummy cheeseburger goes to the chylomicrons, gets dumped next to your left subclavian vein. It'll be cleaved by lipoprotein lipase in your muscles and fat, and the free fatty acids go into the muscles and the fat. The glycerol and the remnant are either go to the liver, and the remnant is sometimes incorporated into HDL. All right, so you can see here, there's this pathway, that pathway. We're not going to elaborate on this right now. All right, so now we're going to focus on it a little bit more. So the liver is going to secrete a very low density lipoprotein, which gets cleaved by lipoprotein lipase. And that gives rise to an intermediate density lipoprotein and some more free fatty acids, and those get used by peripheral tissues. Now, IDL can be further broken down into LDL, and the LDL is absorbed by the liver and the peripheral tissues by the LDL receptor. This is important. You must know this because there are things we can do to manipulate the LDL receptor using PCSK9 inhibitors. That is important. You must know it. All right? So that's one step of how we control cholesterol. The other way we control cholesterol is by the hormone that's the rate limiting step for cholesterol synthesis. But anyways, once the LDL is bound, the receptor is endocytosed, and the LDL is metabolized into cholesterol and esters. All right? And those get released back into serum. And the endocytosed LDL inhibits HMCoA reductase, which is the rate limiting step of cholesterol synthesis, and we'll see it in a second. The big point here I'm trying to make is that LDL sits on its receptor. The cholesterol binds the receptor comes in, all right, and then two things can happen. The receptor can be degraded or recycled. So it goes back to the membrane, so it can bring more LDL into the liver. We use PCSK9 inhibitors to keep more LDL in the liver cell membranes because by using the PCSK9 inhibitor, you prevent the degradation of the LDL receptor. And this allows the LDL receptor to be recycled. And if the LDL receptor can be recycled, it stays in the liver membrane. If it's staying in the liver membrane, it can pull more LDL into the liver. And that means you're not as likely to die of horrible cholesterol disease when you eat too many cheeseburgers, although you still can. So here are the lipoproteins themselves. The big one I really want to point out is LDL, right? VLDL becomes IDL, becomes LDL, and the tissues absorb this for cholesterol. And the enzymes that you need to know are the LDL receptor and clathrin-coated endocytosis. All right, so again, there's the LDL receptor, the LDL binds, these clathrins, they just sort of, think of it like puzzle pieces that sort of form around the endocytosing vesicle, and they coat it, bring it in, and then come off. All right, and the big thing you need to keep in mind with LDL is atherosclerotic disease. All right, you can also have arcus corneae and xanthomas. All right. This is Arthas corneae. You can see this sort of glossy lipidy appearance. And here's an eruptive xanthoma. As you can see, it can sort of mimic, what's it called? Herpes zoster. It could trick you, but it can also look like this. So if a patient is presenting with eruptive something like this, and there's no infectious cause, and you've ruled that out, consider inborn errors of metabolism. So we're not going to talk too much about apolipoproteins. There's just a couple of, important points that are testable. Apolipoprotein E4 is associated with Alzheimer's disease. It's associated with increased risk and earlier age of onset. You must know this. ApoE4. ApoE4. E2 is protective, but what's more important for you to know is that ApoE4 is associated in terms of increased risk and earlier age of onset for Alzheimer's disease. B48 deficiency is involved in A-beta lipoproteinemia, but we'll talk about that in a different lecture. ApoC is involved in activating lipoprotein lipase, so problems with ApoC lead to problems with lipoprotein lipase. Loss of function in apoproteins A2 and A4 lead to hypercholesteremia. Why? Because A1 activates LCAT, and LCAT is what takes the cholesterol esters and puts them in the HDL. Most plasma cholesterol is supposed to get trapped in the HDL by LCAT. So if you don't have A1, you have problems with LCAT. And A2 and A4 transfer phospholipids to HDL. All right. So I didn't mention 1 here, but if you lose 1, 2, and 4, you can see why there's problems because you don't have the good cholesterol. HDL is what you want. You want most of your cholesterol to be esterified and trapped in HDL. LDL is what gets oxidized and causes atherosclerotic heart disease. So here's the synthesis of cholesterol. As you can see here, the rate limiting step is sorry, I have to sneeze. I'm going to pause. Sorry about that. As you can see, the rate limiting step is HMG-CoA reductase. And what's going to activate it? Insulin, of course, because you have high energy. When you have high energy, you want to make your storage stuff. So insulin switches on cholesterol synthesis, and cholesterol inhibits cholesterol synthesis. But please do not try to eat cholesterol to lower your cholesterol synthesis if you have high cholesterol. Please do not do that. Now we get to sphingolipid synthesis. All right, this is the fun stuff. This is the fantastic stuff that every medical student dreams of. All right, so sphingomyelin is nervous system tissue. Gangliosides are the ganglia of the nervous system. Sulfatides are in nerve cells, and cerebrosides are found in CNS myelin. So basically, you can see how an issue with sphingolipid synthesis is going to lead to neurological defects. All right, you can see there's a pathway here, there's a pathway there, there's a pathway down here, there's a pathway over there, here, there, everywhere there's a pathway. All right, the 2 big steps I want you to keep in mind. The main thing I want you to know right now is that palmitoyl CoA and serine form ceramide. Palmitoyl CoA and serine give rise to ceramide. Ignore these steps here. I just want you to know you start with this and you eventually end up with ceramide. And then ceramide can go through all sorts of pathways to become the other molecules. And breakdown of sphingolipids occurs in the lysosome. So I highlighted a couple. Technically, you need to know all of them. I picked the ones that I've seen the most, but that's completely subjective, all right? That is completely 100% subjective. You could get any of these, all right? You can get any of these. So the ones I'm going to point out right now are hexosaminidase, glucocerebrosidase, and sphingomyelinase. All right. Why? Because I'm sure most of you have heard of Tay-Sachs. It is a very common mutation in the Ashkenazi Jewish population. 1 in 30 are carriers. Almost everyone with that ancestry gets screened for this. All right. The other diseases tend to be a lot of autosomal recessive diseases tend to travel in Ashkenazi Jewish families and a couple other specific ethnic groups. But the big one you have to know is Tay-Sachs. All right. If your question stem gives you the picture of like a neurological deficit kid of Ashkenazi Jewish ancestry who's presenting with blah, 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 you need to know that's Tay-Sachs. I cannot emphasize this enough. And there may or may not have been a movie about this called Lorenzo's Oil, but I could be mistaken. I could be mixing it up with adrenoleukodystrophy. But anyways, glucocerebrosidase is the second one that I really want to point out, and that breaks glucosyl down to ceramides. So you get these buildup of these glucosylated ceramides, and that leads to Gaucher disease, which is a kind of a more brutal version of what happens with the other gangliosidoses. Try saying that 5 times fast. And sphingomyelinase is important because that's what breaks down sphingomyelin into ceramides. So you get this excessive sphingomyelin accumulation that leads to Niemann-Pick disease. All right, and we'll talk more about those later. And on paper, you're responsible for all of these, but these are the 3 that I'm choosing to emphasize. In other lectures, I've talked about phospholipid synthesis and how they're involved in cell signaling, and I would refer to that if you want to recap. All right, cases. Little boy with an unusual viral illness. You are an emergency room physician at a small rural hospital. A 5-month-old boy presents to your emergency room after suffering a seizure at home. He's acutely lethargic. All right, I'm going to drink some tea. I want you to put yourself in the head of this emergency room physician. I want you to think, this kid that just showed up, super lethargic, all right, and had a seizure. What's on the differential? So metabolic errors, yeah. So seizures of unknown origin, infection, especially in a 5-month-old that hasn't really started their vaccination series. So you want to think infection. You want to think about what's it called? Inborn errors of metabolism. I don't want you to put blinders on just because we're talking about inborn errors of metabolism. I want you to think big picture. All right. Mass occupying lesions, aka tumors or cancer, those can definitely cause a seizure. So those are just some things that you need to have on the differential, but they're big do not miss items. Those are things you don't want to miss. You don't want to miss the inborn error of metabolism. You don't want to miss the tumor. You don't want to miss the infection. All right. And there are also some seizure syndromes. But in a 5-month-old boy, your threshold of suspicion has to be much higher because they're very frail. You learn that the patient had a GI infection with vomiting and diarrhea over the last few days. So you know that the patient was healthy, had these stressors, this intense physiologic stress, and decompensated. All right. You do your physical exam. They have hepatomegaly. Their lab studies show hypoglycemia and hyperammonemia. All right. Now, what do you need to worry about? Someone comes in with low blood sugar, they're lethargic, and they had a seizure. All right. You need to worry about diabetic ketoacidosis. That's actually not the answer here, but you do need to worry about it. All right. So now that you see that the person has hypoglycemia, what labs do you need? If you said ketones, you would be right. Also, it's written right there. Good job. All right. So if you read that or knew it, bravo. And if you're reading this as like an M2 or an M3, etc., who's already learned about acid-base physiology, don't worry about the acid-base disturbance at this time. We'll talk about it on the next slide. But the presence or absence of an acidosis can clue you in as to whether it's diabetic ketoacidosis, which this is not. He's hypoketotic. He does not have extra ketones. All right, which in other words, he is not generating his extra source of energy. Because what ketones do normally is you drop in blood sugar and you make ketones. This little boy had a drop in blood sugar because of his infection, but he never made ketones. This 5-month-old did not make ketones. You have to ask yourself why. There's only one reason. Inborn error of fatty acid metabolism. All right. You don't have ketones. You need ketones. There's no beta oxidation happening. So it's either a problem with the oxidation enzymes or something else. And we'll see in a second. So the culprit here is medium chain acyl-CoA dehydrogenase deficiency. It's a loss of function of the acyl-CoA dehydrogenase. All right, beta oxidation gets impaired and that causes an energy deficit. And there's some liver damage that goes along with it because the smaller acids start to accumulate. Now, the presentation happens very early in infancy and childhood. You get a hypoketotic, hypoglycemic encephalopathy versus a hyperketotic encephalopathy that's hypoglycemic in diabetic ketoacidosis. Why? Because your blood sugar has tanked so low, and this typically happens in can happen in either type 1 diabetic or type 2, so don't stress out about that specifically. The point is what happens is your sugar goes down. All right, your blood sugar goes down, especially type 1 diabetics. Your blood sugar goes down, and what does your body do? It enters beta oxidation to provide energy. What's the problem with that? Ketones cause acidosis. All right, so here the symptoms were triggered by viral illnesses and fasting. And the only way you can differentiate this from diabetic ketoacidosis is by the absence of ketone bodies. It might not be the only way, but it's a good way to differentiate it, because DKA might present with a profound metabolic acidosis secondary to the ketone production. All right. And in MCAD, you're going to have some elevated liver transaminases. All right. The hallmark phrase is hypoketotic hypoglycemia. That might be hyperammonemic. Okay. And you're going to avoid fasting. And how are you going to treat? You're going to give dextrose, which just has sugar. It's basically sugar water that you inject through an IV. All right. So that one's out of the way. Now, a similar clinical picture presents in systemic primary carnitine deficiency. Same exact issue. Before it was you didn't have MCAD to process the fatty acids. Here your carnitine shuttle doesn't work, so the fatty acids are never getting into the mitochondria to begin with. So you have the same end result, which is lack of beta oxidation. So it'll present with hypoketotic hypoglycemia, but it'll involve muscles as well. All right, so the systemic primary carnitine deficiency will involve muscle weakness and smooth muscle dysfunction. All right, so you can replete carnitine. Otherwise, so you can give carnitine, but otherwise you're going to manage things similarly as MCAD. All right, dextrose infusion when necessary. And both, at the end of the day, both syndromes arise because a lack of beta oxidation, which leads to a hypoketotic hypoglycemia, as opposed to diabetic ketoacidosis, which is going to lead to a hyperketotic hypoglycemia. All right, case 2, unnaturally sleepy infant. A 9-month-old girl of Ashkenazi Jewish descent presents with increasing lethargy. What do you want to know? What do you want to know about the lethargy? When your 9-year-old girl shows up in the clinic, what do you want to know? All right, now you might have just read the next sentence. Do you want to know, did this happen overnight? Right? Is it like the other kid? The other kid was like, "Oh, I'm all good and dandy," and boom, seizure, acutely lethargic, hypoglycemic hypoketosis, almost dead, borderline of death. That kid in the last case could have died. That's an emergency. All right? And we screen for those things at birth. But let's say someone, and by the way, on STEP, they love to do that. They'll say the person immigrated or was adopted or born outside the country, because that might be a country that does not screen for these disorders. All right. So they might have a later onset of them and it was asymptomatic the whole time, but they weren't here. So when they were born, they weren't screened for it, because not all countries screen for the inborn errors of metabolism. All right. That's just a little trick. When you see immigrant, or you always want to think about vaccinations, screenings, what sort of thing is not, because in America, the health system is pretty regular in the sense that certain diseases just get screened at birth. There's just federal policies, and certain vaccinations are, sort of enforced through the school system to an extent. There's loopholes and stuff. But when someone comes from a different country in a question stem that can point towards, they might not have been, for example, they might not have been treated for antibiotics for a staph infection or strep infection, and now they have rheumatic fever. Or they never received their vaccines, and now they're presenting with, I don't know, zoster or something. Or what else? Or inborn error of metabolism, just things like that. All right, so that's my little tidbit for you. All right, so this has gotten progressively worse. This is a more long-term process that's going on with this girl. She has a fixed gaze, macrocephaly, hyperacusis. She has a pale macula and a cherry red spot. So you have some pretty notable physical exam findings. I want to point out the cherry red spot, hyperacusis, which means things startle her more easily because she's hyperacute. She can hear things way more easily. Acoustic. Okay? She has a fixed gaze. What kind of picture has been painted to you? And do you think there's treatment options for this patient? And from the way I said that, you're probably thinking no, in which case you'd be right. This is Tay-Sachs disease. It's an autosomal recessive mutation in hexosaminidase A. This lysosomal enzyme breaks down gangliosides. Deficiencies of the enzyme lead to accumulation of toxic GM2 gangliosides and subsequent progressive neurologic disease. You have loss of motor function, lethargy, and macular pallor with cherry red spots. All right. This is a very poor prognosis. All right. There's a lot of recommendations for increased screening in the Ashkenazi Jewish population, as 1 in 30 are estimated to be heterozygous. Now we get to Sandhoff disease. So those are like the two GM2 gangliosidoses. Sandhoff is the more severe version. All right. So similar disease stuff, just know Sandhoff is more severe with seizure activity. All right. So case 3, an adult with gait ataxia and early onset dementia. A 42-year-old presents with early onset dementia and gait difficulties for the past 3 years. So now you have to think about things that are less lethal, right? You don't think this guy has Tay-Sachs, right? You don't think this guy has, like, I don't know, Frederick attack, like the things that present in infancy, teen years, adulthood. You got to be more nuanced because he's older. All right. So whatever this is something that is not lethal enough to kill him when he was little. All right. So that's your differential. You want to think of things that are not super lethal, but might be now. So you do a workup for the typical causes of dementia, right? No pertinent pauses. We're not going to do a discussion of dementia right now. It's way beyond the scope. There's no family history of neurodegenerative disease. There are no structural lesions observed on imaging. A variety of metabolic diseases are screened for using an enzyme assay, and this patient is found to have diminished beta-galactosidase activity. And that's GM1 gangliosidosis, all right? I'm not going to beat a dead horse here. There's multiple forms. You can read this in your own time. What I want to point out is this theme that accumulation of gangliosides leads to progressive neurologic damage. So, case 4, seizure, spasticity, and bone marrow abnormalities in an 11-month-old boy. So you already get the picture that something bad's about to happen, right? Seizure, spasticity, and bone marrow abnormalities in a kid that's 11 months old never sounds good. All right. What's your differential? It should be tumor, tumor, and tumor, and then inborn errors of metabolism. All right. So his physical exam shows failure to thrive, diminished vision bilaterally, hepatosplenomegaly. And I kind of gave away this answer. Where is your barometer for how seriously sick this patient is? And you kind of want to do that on clinicals. And if you're watching this, you're probably an M1 or an M2, and it's not going to be, you don't have enough experience to recognize this. But one thing you'll very quickly in rotations realize that you have to do is you really need to understand how sick, which patients, because you might have, like, I'm on my surgical rotation right now, and I had 13 patients on the service that I had to keep track of. Some patients I paid a lot more attention to than others, and I triage it by, you've got your very sick patients, like they're in the surgical ICU, and those, ironically, you don't have to monitor as much because there's a surgical ICU team right there, but you're going to be following those patients and their charts, etc., more closely. You're going to be really on top of all the orders, making sure everything's being done correctly. You're probably going to see this patient multiple times during the day. Then there's the patients that are sick, right? You're going to check in once or twice. And then there are the patients that shouldn't be there, like the Munchausens, and like, oh, my stomach hurts, everywhere. You do a CT scan, there's nothing. You can't even call it biliary dyskinesia, like there's just nothing. And it's anxiety or IBS, but you can't tell the patient that, so you're going to take some couple $1,000s, work them up, and then tell them that they have got nothing wrong with them. But the point is, this boy, where does he fall on your barometer? And he should fall under very sick. I mean, when a kid is coming in with shortness of breath, seizures, and spasticity, that kid is half foot. I mean, it just takes one bad day for this kid to die. All right. So, and look, sometimes they don't look, on the outside, they might look fine, but you have to look at the clinical picture. I mean, just recently, again, on the surgical rotation, we had this patient. Oh, she was so chatty. She was in a great mood, laughing, smiling, joking around. My attending had a gut suspicion that she might have perfed her colon, even though she looked fine. She didn't look septic, right? They go in and the thing's perfed. They take it all out. She still goes into septic shock. We caught it just in time to save her life. If we had left that, if we had gone by how the patient was talking and behaving and not followed the clinical symptoms and the facts were she was getting more distended and she was having more pain and more nausea. That all pointed to a process getting worse. So that patient was sick, was very sick actually. But on the outside, they were all cheery and gloomy. So you really need to look at the patient and be able to triage. Are they very sick, kind of sick, not sick at all? All right, so this boy and the patient I just described would be under very sick because if that woman had not gone to surgery that afternoon, she would not have made it to the next day. Or if she had been sent home, she would have perfed at home and died from septic shock. All right, so now this kid gets a bone marrow biopsy positive for foam cells containing sphingomyelin and cholesterol, so excess lipid products. The lung biopsy also shows foamy macrophages, and now you have your answer. All right, you see you've got your sphingomyelin. You can assume the nervous system's involved. Seizures. Lung biopsy shows foamy macrophages, shortness of breath, and spasticity. Also, C sphingomyelin. All right, Niemann-Pick disease. It's an autosomal recessive loss of function mutation in sphingomyelinase. Now, these foam cells that we're talking about are activated macrophages, and an activated macrophage can be called a histiocyte. And it tries to capture the sphingomyelin and break it down. And it's kind of similar to how macrophages or macrophages, depending on, phage, whatever, fits better on your page, but it'll capture LDL and break it down and oxidize it, and that's part of the pathophysiology of atherosclerosis. But it's a similar theme where the macrophage is like, they don't belong here, and it goes to break it down. Or like when macrophages break down iron and they become they've got like iron granules in them. They become brown, pigmented macrophages, whatever fits better on your page. But as this accumulates, you get this dysfunction, right? The macrophages can really only keep up for so long. All right. And where do you find macrophages? You find them in the brain, liver, bone marrow, and lungs. You get these bone marrow abnormalities. You get these liver and spleen abnormalities. You get these brain abnormalities and lung abnormalities. You might be, what? Macrophage in the liver? Why? Actually, they're called Kupffer cells, and they're important because they hang out in your sinusoids. So it turns out the sinusoids of your liver are pretty crappy at keeping bad things out. They're designed that way because so much needs to be detoxed, absorbed, metabolized, etc. in the liver that it needs to be nice and permeable. The problem is it's a little too permeable, a little too friendly, a little too eager to accept weird fluids from the outside world. So these macrophages hang out in the liver. So if I were to draw it out for you, let's say this is a sinusoid, right? There are these venous vessels with these gaps in them. And, it's a perfect entry for a bacteria looking to penetrate and cause some serious damage. But you got this guy, this happy macrophage, and he says, no. And then he eats you. And everyone lives happily ever after. All right. So that's why you get these liver and spleen abnormalities, etc. Lungs, lungs have macrophages because dust. In fact, when you dissect the lung, if you look, you can see all these black dots, sometimes greenish dots all over the lungs. And those are actually dust deposits, macrophages that have just eaten dust. And, they just consolidate there. All right. And in the bone marrow, it's a long story. We're not going to go there right now. And then there's the brain. Now, when we come down here, all the types can lead to mental retardation. That shouldn't shock you. Sphingomyelin, it's in the brain. Too much of it, problems in the brain. Hepatosplenomegaly, problems with the macrophages that are in the... we didn't talk about the spleen. We talked about the liver. So there's macrophages in the spleen that just sort of hang out. And if they see a red blood cell that gets trapped in the spleen, it means that the red blood cell doesn't have a good shape anymore. So the macrophage says, hey, I'm an extremist. You're not a nice circle. I don't like people that aren't nice circles. And the macrophage eats it. All right, so that's what leads to the splenomegaly. So you get hepatosplenomegaly. Why? Because in the spleen, the macrophages break down red blood cells that don't have a good shape or are infected with something inside them, or gram-positive organisms like staphylococcus, etc. That's why people without spleens need vaccinations against encapsulated organisms. But going back to the point, and in the liver, you've got the Kupffer cells, or these macrophages that just grab whatever's trying to sneak through the sinusoids. All right, so you get hepatosplenomegaly for that reason. You get this intermittent pulmonary involvement. These macrophages, they get angry, swollen, etc. Inflammatory processes leads to, chronic infection, and chronic infection leads to decreased oxygen in the lungs. And lungs, when they don't have oxygen, they constrict, they just squeeze. All right, and that leads to pulmonary hypertension. All right, what does that cause? Well, if your pulmonary artery has so much tension, why does it have tension? Because your vessels are all constricted and hypoxic, right? Because there's no point in sending blood. If you're a lung and you don't have oxygen in that part of the lung, why are we sending blood there? That's ventilation perfusion mismatch. You're ventilating the lung, like there's no ventilation in that lung, there's no oxygen in that part of the lung, but you're still sending perfusion there. Doesn't make sense. So the lung, its natural reaction is to constrict. However, that constriction leads to higher, especially if it's global, leads to higher pulmonary arterial pressures, and over a long time that causes remodeling and pulmonary hypertension, and that pressure backfeeds from the pulmonary artery into the right ventricle and right atrium. Remember, those are supposed to be very low pressure circuits. Their job is just to go to the pulmonary arteries, which are supposed to also be a low pressure circuit. Then the left atrium, which is higher but still relatively low, and then the left ventricle is what generates force. The problem with pulmonary hypertension is that you get this burnout of the right ventricle, and you then eventually leads to right-sided heart failure or cor pulmonale. So that was a lot of information I just threw at you. The good news is you don't need to know too much of it. I just wanted to give you it so you can remember what Niemann-Pick does. So Niemann-Pick disease leads to lung disease because of the macrophages in the lung, and the macrophages in the lung cause this inflammatory process and vasoconstriction. The vasoconstriction causes, so you have these repeated infections. That's one end of it, but the vasoconstriction leads to increased pulmonary pressures, and that backfeeds onto the heart, and then the heart gets these increased pressures, and that leads eventually to congestive heart failure, or right-sided congestive heart failure, or cor pulmonale. On top of that, so that's the lung stuff. All right, why? Because these histiocytes are in the lung. Now we move to bone marrow. You get bone marrow abnormalities. All right, and then you get to the liver and the spleen, right? The liver has the Kupffer cells and the sinusoids. The spleen has its own sinusoids. And then there's the brain where the sphingomyelin is, right? So that's why you get all these systems involved, all right? And that's why Niemann-Pick disease's prognosis is so bad, all right? And the earlier it presents, the worse it is. Gaucher disease is different, all right? So you get these Gaucher cells that are lipid-filled macrophages. It's kind of similar, but they're not histiocytes. They infiltrate and cause infarction and necrosis, and that turns into destruction of the bone. So if you see this picture that's like you have lipid-filled macrophages and destruction of the bone, Gaucher disease. All right. If you want to think about, I'm going to give you this isn't why it has this name, but it's one way I remember it. If someone's bones are all messed up, they'll be walking weirdly, or gaucher, if you will. Gaucher means like not fitting in, kind of weird, not following etiquette. So Gaucher cells have these lipid-filled macrophages, that are not following etiquette, and they destroy the bone, etc. And you don't actually get a limp per se, but just pretend that, if your bones are destroyed, you have this like weird walking gait, and weird Gaucher disease. So that's how I tend to fit it together in my head, but you're free to make your own mnemonics. The bigger point is that the buzz phrase you're going to see is bone marrow biopsy revealing wrinkled tissue paper appearing macrophages. And the type 1 version, the adult version, presents early in adulthood with myoclonic seizures and aseptic necrosis of the femoral head. Aseptic necrosis of the femoral head is a buzzword. So if you see aseptic necrosis of the femoral head and bone marrow biopsy reveals wrinkled tissue paper appearing macrophages, those are Gaucher cells, and that is aseptic necrosis of the femoral head. That should really raise your suspicion for this disease. All right. So neuropathic pain and telangiectasia in a 14-year-old. A 14-year-old boy presents with episodic burning pain in his extremities during basketball practice. This feeling happened before during other practices, but also about a year ago when he had some bad gastroenteritis. His physical exam is pertinent for skin findings of telangiectatic skin lesions that are dark red and non-blanching. He has had many of these lesions, and further history elicits that his maternal uncle had these same lesions and died of renal disease. His grandmother's father also had this disease. The patient himself has elevated creatinine of 1.1 from his baseline of 0.8. What is the pattern of inheritance? All right, I'm not going to draw full pedigree, but let's think about it. Okay, grandma's pa has it. All right, so dad, actually, let's draw a square for dad, affected. All right, he has a daughter, unaffected. Grandma, or the mom, also unaffected. So you know this guy was affected. So he was X affected Y. Okay, and because his daughter is a girl, he could only give an X chromosome. Or not daughter's a girl because his daughter is a female, he can only give an X chromosome. All right, over here we have grandma's mom, who may or may not, we don't know. We really have no way of knowing whether she has, which of these she has. All right, whether she has affected or not, because this is probably a recessive disease. Point being, unaffected mom, affected dad creates unaffected daughter who is definitely a carrier, at least. But the mom, if she had gotten another version from the mom, she would have been symptomatic. So we can assume she's heterozygous. Okay, so we're going to put XA and XR. R, I guess I meant real or normal or whatever. A is for the abnormality. All right, so now we go here. So here's the grandma and the mom. She has a daughter. That's fine. All right. Probably thanks to an unaffected dad who gives a nice and juicy, healthy chromosome. And then we don't know what the daughter got from mom. But the son only gets a Y here. Y here, and now this is that uncle, the maternal uncle. This is him. All right. That's the mom. That's the uncle. That's the grandma. That's grandma's father. All right. So what do we think about this pattern of inheritance? It's only affecting males and skipping generations. Oh, and who's affected? The son. Interesting, very interesting. This tells us that we are dealing with an X-linked recessive disease. All right, why is it not X-linked dominant? Otherwise, mom would have had it and grandma would have had it. All right, so we're dealing with an X-linked recessive disease. We're seeing male mainly affected. All right, and what does creatinine tell us? You won't know this, so I'm just going to tell you what creatinine tells us. This gives us a marker of kidney function. All right, so the fact that the maternal uncle died of renal disease, and this patient himself has elevated creatinine, and he has, so the criteria for an acute kidney injury is 0.3 more than baseline, and there's like a couple other criteria, but one of them is being 0.3 higher from baseline. So this person has an early stage acute kidney, or stage 1 acute kidney injury. All right, so something happened. It's happening to his kidneys. It's happening to his extremities. This is Fabry disease. It's an X-linked recessive defect in alpha-galactosidase A. So what you want to look for is these acroparesthesias, these burning with increased activity. Remember, he felt it during practice and when he got really sick. So it's physiologic stress that triggers this, okay? And you get this renal disease and this nerve involvement, these acroparesthesias, acro meaning tips of fingers or tips of toes. The point is the extremities burn, and they really burn. Other things that happen are hypohidrosis, and they'll have angiokeratomas, which are small punctate. You want to think of like as if the fangs of a viper went and punctured the skin like that. All right, these small punctate, non-blanching, meaning when you press on them, the color doesn't go away. They're dark red skin lesions. All right, so that's sort of what you're going to see in Fabry disease. Now we're going to quickly cover the leukodystrophies. What I want to point out here for Crab, and you can read this on your own and pause the slide and read, what I want to point out is that in Crab disease, you get neuron damages and there's globoid cells on gross pathology. For metachromatic leukodystrophy, you'll have metachromasia of the nerve. So basically the nerves shift in color. It might be greenish or however it's described, but the nerves don't stay in the color they normally do. They stay in this different bright color instead, and that's metachromasia. In adrenal leukodystrophy, you're going to have these neurodeficits and Addison's disease, which is like symptoms of adrenal dysfunction, like low blood pressure, etc., hyponatremia. So Farber disease and sialidosis. For Farber disease, you're going to think arthritis with joint swelling and contracture. Normally, you see contracture in long-standing inflammatory rheumatologic conditions. You wouldn't really see it in an infant. In the absence of birth deformities. All right, so that's Farber disease. It's because of the arthritis. It causes this swelling and chronic inflammation that leads to contracture. All right, which normally doesn't present till way later with things like rheumatoid arthritis. All right, so it's not normal in infants. If you see arthritis and joint swelling, contracture, you got to think about, is this autoimmune or is this inborn error of metabolism? All right, it has a poor prognosis. And sialidosis, so if you see seizures and a cherry red spot, but it's not really a Tay-Sachs picture, etc., or any of the other diseases that we talked about, think about sialidosis. I personally don't think this will show up, but people have been proven wrong before. And like I said, the mucopolysaccharidoses and the cholesterol disorders will be discussed in a different lecture. Thanks for tuning in.